All right, it's 2 o'clock, and we said that we would go ahead and get started promptly at 2 here today. So we'll go ahead and do that when no more people will be coming. If you guys want to go ahead and you can turn off your videos and audio, and we're going to record this so we can send it out to all of you so you can reference it again. And then for the people who are unable to join us, we will have them, or they'll be able to access this as well. My name is Emily Estes. I am the owner of Sage Nutrition, and we are very excited to be able to bring you this presentation on utilizing a multidisciplinary team approach for eating disorder treatment. This is something that Tiffany and I have talked a lot about over the past couple of years, and wanting to be able to offer this in the community, and we're excited to be able to do that today. So as I said, I'm owner of Sage Nutrition. I'm a registered dietitian, and primary focus of my work is eating disorders. And I work collaboratively with all of these other ladies helping facilitate this today. So I'm going to go ahead and give them the opportunity to introduce themselves.
I'll go first. I'm Tiffany Eisenbraun. I am a licensed independent mental health practitioner here in Lincoln, Nebraska. I'm also the director of behavioral health at Affinity Community Counseling, a group practice here in Lincoln. I worked with Emily for a few years now, and we really embraced this. And like she said, it's been a couple years in the making that we've been talking about this. I'm really excited to share our knowledge with you today.
I'll go next. I'm Liz Baker. I'm a dietitian, also with Emily at Sage Nutrition. I was fortunate enough to connect with her when we moved back to Nebraska from St. Louis. And in St. Louis, I worked at a residential eating disorder treatment center. So that's my background.
All right. Well, my name is Sarah Holtz, and I'm a family nurse practitioner. I've been a provider for 10 years. I currently live in Scottsdale, but I've spent the large majority of my career practicing in Lincoln, where I had the opportunity to collaborate with mutual patients and work alongside Liz, Emily, and Tiffany, who truly are the experts in this field. I have learned and continue to learn so much from you guys, and I know that you all will as well. So thanks for taking time out of your busy day to be here with us, and I'm so excited to be here to present.
Awesome. Yes. We are going to jump in with just some brief objectives that I want to cover that we're going to go over today. We're going to very briefly review eating disorder diagnoses. I'm not going to spend a lot of time on it, but I do want to touch on the variety of them and the definitions of them. We're going to identify members of the multidisciplinary team for eating disorder treatment, educate on how to identify individuals who might be struggling with food, weight, and body image issues, defining the roles that each of us hold in a multidisciplinary team, and then identifying strategies for early detection and intervention. So the different diagnoses, moving this around, we have the classic ones that you're going to hear a lot about are anorexia nervosa, bulimia nervosa, and binge eating disorder. So we are going to go into those a little bit more in depth. I also want to highlight other specified feeding and eating disorders. So when somebody doesn't meet the criteria for some of those more familiar names to us, there is the definition of other specified feeding and eating disorders that we're going to touch on. Just to help in identifying and naming the array of eating disorders that exist, we have pica, rumination disorder, avoidant restrictive food intake disorder, which is ARFID, and then unspecified feeding or eating disorders. So we're not going to go into those as specifically today, as well as the muscle dysmorphia and orthorexia nervosa is a proposed criteria coming out hopefully in the next DSM. So to highlight the broad complexity of diagnosing eating disorders and the range of which those diagnoses can come, I just wanted to note all of them, and then we're going to dig in a little bit more specifically. So anorexia overall is a restriction of energy, that it is significantly less than what is needed by an individual. The traditional anorexia nervosa diagnosis also indicates that somebody is significantly low within their body weight in the context of their age, sex, developmental trajectory, and physical health. So the low weight is part of the criteria of anorexia nervosa. There's also the intense fear of gaining weight. There's a significant body image component to this, and then disturbance in the way in which one's body weight or shape is experienced, despite, whatever their low body weight is, of having a lot of disturbance around their body weight and shape. Some of the subtypes we do have restricting. So and looking in a window of a 3-month period, the individual has not engaged in recurrent episodes of binge eating or purging. So restriction is just primarily restriction without those other behaviors. But we also have a subtype of binge eating and purging in which the individual has engaged in those recurrent episodes. For bulimia, this is identified as recurrent episodes of binge eating, which a binge is eating in a discrete period of time. So we would identify that as a 2-hour window generally, an amount of food that is definitely larger than what most individuals would eat in a similar period of time. So that can really mean a lot to different people and how they define that. But so it's very generalized in that regard. And then having a sense of lack of control over eating during that episode. For bulimia, it's also having the recurrent inappropriate, sorry, that word should be merged there, compensatory behaviors in order to prevent weight gain. So this could be the use of laxatives, vomiting, diuretics, and other medications, or fasting, compulsive exercise, in order to try to compensate for what they have eaten. The binge eating and inappropriate compensatory behaviors occur at least once a week for a 3-month period. So we are looking at some of those timelines within this. Self-evaluation is unduly influenced by body shape and weight, and so the preoccupation of that as well. Important that this does not exclusively occur during anorexia nervosa, that these are 2 separate diagnoses. For binge eating disorder, which is our most commonly diagnosed, most prevalent eating disorder, is the episodes of binge eating. So again, that in a discrete period of time, somebody is eating an amount of food that's larger than what somebody would typically be eating in that time frame, and a sense of lack of control over that. Those episodes are associated with 3 or more of these criteria. They're eating more rapidly than normal. They're eating until they're uncomfortably full, large amounts when they're not physically hungry. So kind of using food in response to emotion or stress as a coping response. They often are alone because of the embarrassment and the shame that's associated with this experience. There's the feeling of disgust, depression, feeling guilty afterwards. And it's marked distress regarding binge eating that is present. So we really want to pay attention to the distress that people experience in relationship to this. And then the frequency of this is on average once a week for a 3-month time frame in order to kind of meet the criteria for this diagnosis. It's not associated with the compensatory behaviors and want to be mindful, again, that it's separate from the bulimia or anorexia diagnoses, and that it's primarily the binge eating behavior that is occurring. For the other specified feeding and eating disorders, these are disorders that are causing clinically significant distress or impairment of social, occupational, or other important areas of functioning. They do not meet the full criteria for any of those eating disorders mentioned above. And some examples of these would be atypical anorexia. So it would be the same criteria for anorexia nervosa, except that despite significant weight loss, somebody's weight might be within or above a normal range. And then purging disorder is a purging behavior to try to influence weight or shape. Again, that could be a variety of uses for that: vomiting, laxatives, diuretics, medications, but it's in the absence of binge eating. So there's a subtype there, or the other specified feeding and eating disorder, where we aren't quite meeting the criteria for binging, but still having the compensatory behavior.
Okay, so this is me, right?
Yeah,
We're going to go into talking about the members of a multidisciplinary team. It's really important to have a supportive team, both clinically and non-clinically. So typically, when I'm working with a client who is meeting those eating disorder criteria or has disordered eating kind of in general, the primary key players that I'm looking at are obviously me as a therapist, getting the dietitian to really get those food recommendations kind of in that relationship with food, that nutritional counseling and those things, and then a medical provider. Generally, this is going to be like a primary care physician, so we can monitor our labs and weight and some of those things. Oftentimes, we may also, in conjunction, have a psychiatric med provider. And then sometimes we see specialists that need to come into play as well. GI doctors are people that we work with. I've also had to work with people who then have to bring in endocrinologists or different things depending on what's going on with the body in conjunction with the eating disorder and what medical things are at play. On the non-clinical side of that, we have things like SAGE offers recovery coaching, which can be really important. Having support group, having other people that can help normalize the behavior, normalize recovery-focused behaviors, and then including family and friends. And a lot of times I'm finding those family and friends is really providing a lot of education around, kind of, here are things that you can do to provide support. Here's the best way to kind of provide support, or sometimes things not to do, or to bring in somebody who just generally knows what's going on and can help with some accountability. So this is a good diagram to kind of look at how we need to surround the person and wrap around that support with people. We have our person who is experiencing an eating disorder, then we have our families and supports, we have our treatment team, and then our other professionals that we need to bring in. And really, it has to be, this is one of the diagnoses and one of the things that we see the most that really need the most collaborative care, because they can be really dangerous disorders to have. And so it's making sure we're treating all symptoms across the disorder.
Are you guys seeing my screen? Because
we can see your screen, but you are green to me right now.
Yeah, I don't know what's happening with that. But go ahead. I'm just gonna turn that off.
That's really fine. So things to think about, average time to diagnose an eating disorder is 4 years. A lot of times when I'm getting requests to collaborate or to discuss client cases, it's a lot of times clients who have been working with their therapists for a significant period of time. And as they're kind of, healing through some of their traumas or their anxieties or these other components that really brought them into therapy, then there's this underlying, disordered eating that's tending to happen. And really, we're starting to see kind of the prevalence of it. We definitely don't want to associate stereotypes with, what an eating disorder client can look like, because eating disorders don't discriminate. A lot of times people think of, like a white, malnourished, young cis female, because that's what media portrays as somebody with anorexia, or they don't hear about other types of eating disorders because anorexia and bulimia are those two that are really prevalent that we hear about in the media. So all of the individuals that come into therapy really should be screened for eating disorders and disordered eating, asking those questions that we're going to dig into in a little bit, or would be really helpful for that. So, things that you may consider in that, either initial diagnostic session that you're doing with a client, or just kind of in your ongoing work, looking around, rigidity. Do they have routines around food? Are there certain times a day they do or do not eat? Are there only certain types of food that they eat? How does the client feel about themselves in relation to their body size? Is that self-worth really tied to how they look or how they perceive that they look? The social withdrawing, showing decreased interest in activities. Are they thinking about food a lot in comparison to, those activities they used to enjoy, or how are those things connected? Do they complain about being cold, tired, apathetic, lethargic? Do you have conversations around food? Are they having a lot of nausea? Are they having a lot of, those GI symptoms, distress after eating or when they're not eating, and kind of looking at some of those components? Do they present concern around weight, size or shape? How are they feeling about that when other people make comments about that? How does that impact them? How do they respond? We want to normalize not making comments about, people's body size and things like that. And, but how did they report their concerns about it? Are they continuing to say, I've gained and gained and gained and gained weight, and you're not necessarily noticing any visible differences? Or, if you're working with a medical professional, they're not, reporting that there's those weight changes. And then, the weight gain and weight loss in a significantly short period of time.
So in terms of how to identify individuals who might be struggling from a dietitian perspective, obviously we're going to be asking questions very directly about the food and about relationship with food history. But some questions might sound kind of similar to what Tiffany was saying, but does my client worry about their weight and body shape more than other people? Does my client avoid certain foods for reasons other than allergies or religious reasons? So like if a client suddenly decides or comes to you saying, I think I want to be a vegetarian or a vegan, and they aren't necessarily doing it for ethical reasons, that's often a little cautionary flag. Is my client often on a diet, or do they have a significant history of maybe yo-yo dieting? Does my client feel their weight is an important aspect of their identity? A lot of times we'll see this in clients who maybe growing up were labeled or identified based on their body size. So if they grew up in a smaller body, maybe they were often called tiny or like a twig, or maybe even shamed for being in a larger body, and clients who were potentially called chubby. And I'm using things that clients have told us before. And so that has become a piece of their identity. And another one is my client fearful of gaining weight? Does my client feel out of control when eating? Are they, with that one, it might be specific instances, but it could be them saying something along the lines of, oh, I don't keep X food in the house because I'll eat it all, or I feel out of control when I eat it, or it's addicting. Something along that verbiage. Does my client regularly eat until feeling uncomfortably full? Or does my client hide what they eat from others in secret? So if you hear oftentimes their meals, or they're eating in their car on their way to and from work or school, or they wait till others go to bed at night, or maybe they hide or hoard food in their bedroom. Those are common things that we hear. Does my client feel guilty or depressed after eating? Does my client ever make themselves vomit after eating? And then does my client use insulin in ways not prescribed to manage their weight? So this is often called diabulimia, and typically might see it in a person with type 1 diabetes, and they might restrict their insulin in order to manage or control their weight. Does my client take any medication or supplement to compensate for eating or to give themselves permission to eat? Does my client exercise for the sole purpose of weight control, or does exercise give them permission to eat, or do they need to compensate for what they ate via exercise? And then have other people express concern about the client's relationship with food or their body?
All right, so we'll spend the next few minutes talking about some of the more common medical problems encountered by those individuals with eating disorders. There's a wide range. Some are mild and can be difficult to measure, which makes it even more challenging to accurately diagnose and treat. But some of these complications can be life-threatening. So it's important to remember that eating disorders can affect literally every organ system in the body. But the medical problems or symptoms that one might experience is often variable from individual to individual. So from a growth standpoint, excessive or rapid weight gain or weight loss should raise concern, as should failure to achieve or maintain inappropriate increases in weight or height, notable fluctuations in weight. From a cardiovascular standpoint, we want to assess for bradycardia, which is defined as a heart rate less than 60, and new onset of a cardiac arrhythmia, chest pain, palpitations, orthostatic tachycardia, or hypotension. I think we tend to, again, think that's more common in a patient who's malnourished, but anytime there's a fluid volume deficit, so purging by either self-induced vomiting or laxative use, that's something that we can see. Shortness of breath, edema in the extremities, or cardiac murmur, especially if that's new onset, that certainly needs to be worked up. From a gastrointestinal standpoint, I do think these are some of the more common symptoms. A lot of individuals with eating disorders have a lot of just vague abdominal pain, abdominal discomfort. It can be localized in the epigastric region. Oftentimes there's bloating, early satiety, reflux, especially if there's any vomiting, you want to assess for that. And is there any hematemesis? Constipation is very common. We won't get into all the nuances of gastroparesis, but that's a very common complication, certainly can lead to problems with hemorrhoids or rectal prolapse. From the integumentary standpoint, patients who are malnourished tend to often look much older than they actually are. We can see that dry and sallow skin, brittle or thinning hair, nails, hair loss, lanugo, that fine hair, primarily on the face in an attempt to keep the body warm. Calloused knuckles, often seen with self-induced vomiting. Poor wound healing, easy bruising, or bruising on the spine can be seen with excessive exercise. And then from an HENT standpoint, particularly with chronic or extensive self-induced vomiting, we can see dental erosions or caries, palatal abrasions, angular stomatitis, sialadenitis, or parotid gland enlargement can be seen with chronic self-induced vomiting. From a neurologic standpoint, orthostatic changes, dizziness, lightheadedness, presyncope, or even syncopal episodes, weakness, memory loss, seizures, epilepsy. And from an endocrine standpoint, patients who restrict calories oftentimes are very cold and have difficulty staying warm. Oftentimes we can see the acrocyanosis, so bluish discoloration to the fingers and toes. Hot flashes or sweating episodes can occur. Stress fractures and low bone mineral density are some common complications, as well as primary or secondary amenorrhea or oligomenorrhea. From a psychological standpoint, reiterate what has been previously mentioned on slides, but excessive concern about weight or body image, inappropriate dieting, including rigidity about types or qualities of food, compulsive exercising, fatigue, insomnia, self-harm, suicidal ideation, and depression, anxiety disorders, OCD, and ADHD, just to name a few, are more of the more common problems.
Now we're going to talk about the different roles that HFS providers can take. As the role of a mental health provider, we want to continue to monitor the mental health issues and underlying issues. Oftentimes, we're not going to see just an eating disorder, right? We're going to oftentimes see trauma, we're going to see anxiety, depression, a lot of other co-occurring issues that go along with it. It's so important to build a trusting interpersonal relationship with clients. One of the most important things about a mental health provider, in my opinion, is the therapeutic relationship that you can have with the client. There has to be a lot of trust there, especially when you're talking about these really complicated issues, especially if you want to start looking at higher levels of care. Having a client trust you to be able to really navigate these difficult conversations is really important. Exploring the nature of the eating disorder. There's a lot of stigma associated with that. There's a lot of messages in the media that we receive. There's a lot of messages we receive from our family about all sorts of different, body sizes, body types, eating habits, and then confronting any of those moral or self-blaming issues. Those are going to be really important things to talk about because these things tend to allow the eating disorder to continue. Eating disorders, serve a valuable function in the individuals and act as an effective distraction from stressors in an attempt to distress tolerance and regulation. So, oftentimes people are struggling to cope, and so they turn to their eating disorder behaviors because it helps them feel better in that moment. And they aren't able to tolerate those more difficult emotions and really kind of collaborate along with that. One of the things that I talk a lot about with my clients is the grief that they have to give up when they're working towards recovery, because their eating disorder has served such a valuable function. They also have to grieve it. And that's a whole other training that we could probably go into. Helping clients reframe and change and develop their alternatives for coping with stressors, talking about ways that they can manage and implement adaptive coping strategies to reduce the eating disorder behaviors. When I have a new client that comes in, it's very rare that I would say you have to immediately stop all your eating disorder behaviors. We have to slowly be able to teach them and integrate into those new coping strategies in order to reduce the eating disorder behaviors because of that function that the eating disorder is serving in their life. We want to be able to provide clients with factual information, providing structure, but also being flexible. Eating disorders can be really tied to self-identity, and being able to kind of have that empathetic approach with them and understanding how difficult even giving up some of these behaviors can be. And creating that safe environment and letting the client really be an authentic version of themselves. A lot of times the eating disorder really helps them put on a mask. And so really helping them kind of peel those layers back and really figure out who they are and what really their goals are outside of the eating disorder in life to live, a fully authentic life.
Okay. I'm sorry, my camera is not working, so I'm here, and this is Emily speaking to you. And we're going to go over the role of registered dietitians. We are responsible for assessing that nutritional status of clients. This is going to look at a variety of things. So we're going to be looking at their attitudes towards food, their patterns, their behaviors around food. Be looking at past and current eating patterns. Like I like going back to, very first memories with food. How has that relationship with food been influenced over the course of time? Are there any compensatory behaviors happening? There's a whole list of what those compensatory behaviors could look like in terms of vomiting, diet pills, laxatives, diuretics, restriction, all exercise. So many different ways that people can compensate. So just trying to be thorough of assessing if they're utilizing any strategy to do that. We want to obtain a weight history, and depending on the age of the individual, it can be really helpful to actually get growth charts from this when they were in their pediatric time frame, to be able to assess more thoroughly, like what is going to be a more ideal weight for an individual, and what has the fluctuations within their weight history been over the course of time. We want to have an examination of the timeline of their relationship with food, weight, and body image. So assessing all of those areas, again, going back to their earliest memories and talking through that up to the current time so that we can really assess all of that. We're reviewing the physical status of a client. We do this in collaboration with a medical provider so we can look holistically at that individual. And challenging client in a safe and structured environment. I think the dietitian is most often probably the most disliked provider on the team. And I've started to embrace that role very well because what we can do is to create an honest and authentic relationship with clients, a trusted relationship so that they feel safe. We give them structure within that environment, and it provides an opportunity for them to be mad and frustrated and put some of that energy toward us as dietitians, but also they know that they're safe to do that. And we're not going to go anywhere. We're not going to abandon them in this, but be able to walk through that with them. In the nutritional rehabilitation, it might involve weight restoration for clients. Overall, we want to be achieving energy balance for what they're consuming, what they're using throughout the day. If they are using compensatory behaviors, we want to begin to withdraw from those and gradually reduce those over time. We want to help them get in touch with their hunger, being able to identify when they're hungry and have more awareness of the cues that their body is giving them. As far as education, we have to talk about weight regulation with clients and how the physiology of the body that goes into regulating weight, how their bodies are really designed to protect them, how all of our bodies are designed to protect us, how we can promote an energy balance with their meal plans, their movement, all of that, the effects of starvation, really any behaviors that they're engaging in. What is the physiological effect of that? What's the short-term, the long-term potential implications of that as well? We do a lot of dispelling of diet myths. There's a lot of diets out there, so people are always bringing new ideas to us. So we get to spend a lot of time deconstructing that. And thankfully, the diet industry just recycles what they've used for the past since the 1800s. So we have a general understanding of the impact of diets. Consequences of purging. That purging can be the variety of different ways that we've mentioned. Fluid retention is often a side effect of some of either the behaviors or it can be in the recovery process. People can start to hold on to fluid just as their body's adjusting and adapting to recovery and getting what it needs. And so it takes education and affirmation that their body's going to be able to sort this out, but it might be uncomfortable and feel a little unfamiliar. We talk a lot about the emotional connections with food and behaviors. I also feel like in our role, we do a lot of work of bringing things to the surface, at which point it's why it's so essential to have this multidisciplinary team, because then I get to contact the therapist and say, hey, these are things that are getting brought up. It's not my role to process that with a client, but we want to work as a team to ensure that we're all on the same page and that those concerns and those connections that clients are making are being able to be processed in the appropriate place. Some of the symptoms that we're monitoring, we see a lot of bloating, that fluid retention, bowel movements, refeeding syndrome is something that we work a lot more like collaboratively with the medical doctor of monitoring that. Changes in their energy level, mood swings they might be having, their fear of weight gain, obsessions that might be happening that they might be turning to, or any restriction that they're trying to use, and their cognitive function. So being in tune to all of that in the process and how those things are being impacted for the client, as well as any preoccupations that might be coming up for them. And awareness of hunger and fullness throughout treatment. So hopefully their awareness is growing throughout the treatment process. We're helping them get more in touch with their body, more in touch with those cues, and allowing them to build the trust with their body, but also giving their body an opportunity to trust them.
All right. So the role of the medical provider really is to manage the medical aspects of care. I won't get into how broken our healthcare system is, but unfortunately, we don't have time in a traditional healthcare setting or office setting or the knowledge base to manage this alone. So that's why a team approach is imperative. But we want to assess, diagnose, and to treat any medical complications. So really that the therapist and the dietitian can hone in, utilize their expertise without being distracted or having the additional challenges of undiagnosed medical issues. So monitoring really, everything is going to be individualized, but we're going to want to do an ongoing assessment of weight and nutritional status from a medical standpoint, monitoring weight and BMI, heart rate and blood pressure. I would also add in orthostatic vital signs are a must. Temperature, assessment of breathing, what is their cardiovascular status? Do they have a new murmur that needs worked up? Do they have edema? How's their peripheral circulation? What's their hydration status like? Examination of head, neck, skin, hair, and nails. Really, I think, medical providers do their patients best when they take a holistic approach that includes an adequate medical history, even if we're not the ones focusing in, on the particularly nuances of the treatment. I do think it's helpful if we can get a 24-hour dietary recall, specifically inquiring about elimination of foods, any binging or purging behaviors. It's not uncommon to have patients who have been previously misdiagnosed either by a medical provider or themselves as having food intolerances or food allergies. So really honing in on that. We want to take a look at the psychological history. What are their current life stressors? Are they having relationship issues? Are there problems at work or home or school that could be a contributing factor? We need a detailed family medical history, as we know there's a genetic component. And then we want to do a thorough medication history. I think, obviously, assessing any use of diet pills or laxatives is self-explanatory. Both oral contraceptives, those really should not be utilized in patients with amenorrhea. Unfortunately, some providers still utilize them in an attempt to jumpstart a period. It doesn't jumpstart anything. All it does is give somebody a monthly withdrawal bleed. So being on the pill really prevents us from being able to fully assess the recovery of the body to the point where the natural menstrual cycle would resume. So the pill really should be utilized. In addition, I would say these individuals really are not equipped to deal with monthly blood loss, which is why the body has stopped giving them their period in the first place. And then non-steroidal anti-inflammatories. If there's chronic use, this should be a red flag, potential indicator of compulsive or over-exercise, and that even despite being in pain, these individuals are pushing through to engage in these behaviors. So any diagnostic testing, again, needs to be individualized, but some common tests to consider would be a complete blood count. We also want to do a basic comprehensive metabolic panel to look at the kidney function, the liver function, the electrolytes. Phosphorus and magnesium aren't typically included in the CMP or BMP, but those oftentimes, depending on where we're at in the refeeding process, need to be monitored. Certain individuals need their hormones checked. A urinalysis can provide key, not just with regard to overall hydration status, but kidney function, electrocardiogram or EKG, x-rays, and many individuals really do need a bone density scan to assess for osteoporosis or osteopenia.
Okay, we're gonna cover a couple of screening tools. You're going to hear probably more commonly one called SCOFF, and I'm going to go over that. But I did want to just share with you all this screening, brief intervention, and referral treatment to for eating disorders. And so if you click that link, which we're going to send this out to you, you'll have that link. But this gives a brief screening tool that you can use. All you have to do is hit get started. It has these 6 basic questions or 5 basic questions of asking whether they throw up because they feel uncomfortably full. If they worry that they've lost control over how much they've eaten, they've recently lost more than 15 pounds in a 3-month period. If they think that they're fat, even though others say that they're thin, and then would they say that food dominates their life? So just for the sake of this presentation, I'm selecting all yes. And what I like about this tool and why I want to send it out is that it tells their risk level. It gives some ideas in terms of the results, some intervention, and plans for how to move forward with that. It also provides responses that you can be able to review. So of how do you speak to this patient? How do you express the concern that you have, and any next steps that you might be recommending? So those are things that I just really like that tool. It could be helpful for you going forward. These are the questions that we just went over. And then the SCOFF questionnaire. So this has for the SCOFF the same questions essentially. It's used in the UK, I believe, is where so it's talking about 1 stone, which is approximately that 15 pounds in the 3-month period. So either of these tools can be really helpful in the general assessment of patients.
So next, we're going to talk about some treatment approaches and some way to approach clients that are struggling with disordered eating or eating disorders. Cognitive behavioral therapy, that's a pretty standard. Most people have heard of CBT, but they don't always know what it is, so really looking at that relationship between their thoughts, their feelings, and then their behaviors. Interpersonal therapy, dialectical behavioral therapy, really looking at building on those specific skills that they can utilize to have those adaptive coping strategies that we talked about earlier. Can you start using these specific skills, this distress tolerance skill, when you're feeling the urge to engage in an eating disorder behavior? Acceptance and commitment therapy can be a really helpful tool. Family-based therapy, you're bringing in the family system, and that family system could be roommates, it could be siblings, it could be parents. It could be just friends who are their support system, but really utilizing that support-based system. Exposure therapy, does a client have a fear food? Do they have a fear meal? Is there a meal that's difficult for them to eat? I've sat in therapy and had lunches. I've had a donut. I've, engaged in those fears with them to be able to process in the moment as they're experiencing those emotions. Narrative therapy, there's a couple different ways I like to use narrative therapy with my eating disorder clients is, having them write their story, talking about their relationship with their, eating disorder, talking about their relationship with food, but then also separating themselves from their eating disorder as well. They aren't their eating disorder. They're somebody who's struggling with it, and kind of utilizing that narrative approach as well. And then group therapy is also an effective tool. You see this a lot more in higher levels of care. I would love nothing more to start a therapeutic eating disorder group here in Lincoln at some point. Just again, my favorite part about group therapy is that normalization, and to be able to lean on supports of people who are walking that same journey.
From a dietitian perspective, in terms of treatment approaches, we're going to individualize it to every client, meet them where they're at within the eating disorder. But we generally incorporate principles of intuitive eating, which is just basically an eating framework that incorporates instinct, emotion, and rational thought too, in order to get to a place where they're more attuned to their body's physical and psychological needs. It's a principle was created by other people, and it's a framework. It has 10 different principles to it. So there's a lot of information about it, backed by research. And then health at every size is just an approach that holds the belief that health is not related to moral value, that treatment should be weight inclusive, and not discriminate against size, body shape, race, basically encompassing respectful care for all bodies.
So coordination and communication is something that's really, really important with the team. So setting up regular meetings or having regular scheduled times or ability to contact in unscheduled times, comparing the information to make sure that we're providing the most comprehensive and cohesive care that we can, making sure that the treatment team is giving similar messages or the same messages to the clients. Communicating level of motivation and participation in treatment. What are their treatment goals? Are they progressing, or is there ambivalence? Are they telling the dietitian, nope, I'm ready to do this, but then communicating to their doctor and their therapist that no, I don't want to do it. I'm not ready. Making sure that that's all there so we can treat them the most effectively. Communicating on the medical status, their stability, their weight, any medical adjustments that are needed. If I have a lot of clients who tell me, oh, I did not tell my doctor that I was purging, or that I've been taking these laxatives or things. I don't think it's important because my weight hasn't fluctuated, but I've been taking laxatives for 3 months. Well, those are important things that the doctor needs to know to be able to make sure that there's not any underlying medical conditions happening. Discuss differences in opinions or perspectives among the disciplines, why the treatment approach might be the most effective. I find oftentimes my treatment approach sometimes does butt heads with some of the other recommendations, just because, we're taking that empathetic approach and trying, not that other providers aren't, but to be able to really dig into the emotional side of things. And yes, the client might need a higher level of care, but there's possibility that they might lose their job or they're going to be away from their children, or there's other components that we really have to take a look at for, those difference in opinions sometimes. Risks of ineffective communication is patient splitting. So this is when a client forms an alliance with a member of, the treatment team and is in opposition to the other treatment members. Well, Tiffany said I didn't have to go to a higher level of care, so I'm not going to do it, and I'm like, well, that's not exactly what I said. So really making sure that we're all on the same page, all having that cohesiveness for the goal of having effective treatment. It's really important to use that client-centered language. Instead of asking, when did your eating disorder start? Ask about what are the symptoms that you experience. Assure the clients that we'll treat this problem together. Identify that the client struggles with an eating disorder rather than saying, I have an anorexic client. I have a client who's really struggling with anorexia. That can make a really big difference. We don't want to identify them by their diagnosis. Also making sure that we're having language accuracy. A binge eating episode is more accurate compared to a bulimic episode. Binge eating episode captures the loss of control experienced during the episode of the binge eating, whereas a bulimic episode implies both binge eating and compensatory behaviors occur. So really making sure we're accurate in those ways we're describing symptoms as well. And use less emotionally charged language.
One more, sorry.
Yeah, you're fine. And remain really weight neutral and discussing any changes with weight with the client. This can be really difficult sometimes, especially when a client comes in really heated. I think the biggest thing that I have seen is, when clients come in really escalated, especially if they're doing a blind weight and then somehow they found out a blind weight, and really having to remain weight neutral and discussing changes with the client. So when to refer. So really the brainchild of this training came out is I was seeing a lot of referrals coming to me when maybe a referral to a medical provider or a dietitian was going to be more effective. So things that you want to consider when referring to a different therapist. I really want you to consider the rapport with the client. If you've been working with this client for 4 or 5 years, is now the time to have them come in and have to build new rapport with a new therapist when maybe they need somebody in addition to, that role as the dietitian to really focus on the food aspect of it. So really asking yourself, would a referral to the dietitian be more appropriate? Can you consult with somebody who specializes in working with eating disorders? I am more than happy to have any conversation with any therapist about, ways to approach eating disorders. And really, when we kind of get to the core of it, treating eating disorders is very similar to treating anxiety, to treating depression, to treating, our trauma. A lot of the things we talk about, a lot of those things. I had a client once who went back to her old provider, and the provider was like, well, that sounds like she's treating your anxiety and, not your eating disorder. And I'm like, well, I'm treating both because they're treated very similarly. So, can you consult with somebody, get some of that expertise, and, potentially make that recommendation or referral to the dietitian in addition to that. And check in with yourself to see what emotions you're experiencing when treating your clients. There's different people who struggle with different diagnoses sometimes can elicit a different emotional response in me. There are certain diagnoses that I get anxious around. And sometimes later on, I'm kind of like, oh, okay, that's what's going on. And check in and just see if there's any of your own struggles that are maybe influencing the way you're perceiving this client as well. And again, go back to that consultation.
Okay, that was a lot of information. And a lot that we went over. So want to open it up. If anyone does have any questions, you're welcome to ask those at this point in time. I am going to be sending out the emails for all of us. So you will get information on how you can reach us individually if you want to ask your question that way. Otherwise, please feel free to ask. You can unmute yourself and ask a question, or you can all open the chat box and